craniofacial symmetry is immediately changing after the adjustment.
Boom.
That's incredible.
It does. It absolutely does.
It's incredible to just even think about the possibility of your cranial bone shifting and changing and balancing out after only doing an atlas adjustment. And yeah, tiny little atlas adjustment to do that. So it's pretty incredible. So on this episode, craniofacial changes after combined atlas-orthogonal and biomimetic oral appliance therapy. Check it out. Okay, welcome back everyone to the Upper Cervical Chiropractic Research Show. This is episode number 28 on behalf of the Council on Upper Cervical Care. I'm Dr. Kevin Leach, and here with me once again, Dr. Tyler Evans. How are you, sir?
Well, how are you?
Doing fantastic. It's been a little while, but we're getting back on it.
Has been.
Getting back on it. Hopefully we'll be doing a lot more here. So this research is called Craniofacial Changes After Combined Atlas-Orthogonal and Biomimetic Oral Appliance Therapy. Authors Singh, Chapman, and Preble. But Chris Chapman, obviously, he's the DC that did it. He's the NUCA doc in Idaho, I believe.
Atlas-orthogonal, careful there,
Utah.
Dr. Leach.
Utah. Yeah, okay. Utah, not Idaho.
Yep.
Atlas-orthogonal. And then, so this was published in Vertebral Subluxation Research Journal in 2014. So we're going on almost 8 years or so.
It's been a minute.
But still good. So there were 11 adults. They went through. So what they did was they calculated. They did radiographs. They did measurements, craniofacial measurements, before an atlas-orthogonal adjustment, after the atlas-orthogonal adjustment, and then after the oral appliance insertion. And so they got and on average, the mean value was about a 22.7 degree deviation from normal. After the atlas-orthogonal adjustment, that went down to 9.7 degrees as a mean. And then after the appliance, it went down to 6 degrees as a mean. So for a total decompensation or change of 68.2 degrees, which is pretty good. So that's those were the findings with the paper. And so, yeah, what are your thoughts, Doc?
Well, so there's a bunch of great things in this paper that bear weight. I think right off the top, one of the most important things is Dr. Chris Chapman is a recent graduate of the ICA Council on Upper Cervical Care. He is just a really well-rounded upper cervical practitioner, been in practice for a while. I don't want to say, I'm going to jump out there and say 20 years.
I'd say 20, I'd say probably
I think he's
at least
approaching,
20,
yeah, I think at least, maybe longer.
Yeah.
But he is just a cutting edge. If he finds technology, he brings it in and he starts to use it. He was one of the first gentlemen to use cone beam CT in a chiropractic practice. In 2011, he started referring to a cone beam CT unit for imaging. And then in 2012 or 13, he actually was, I think, the second doc to have it in their practice, next to, I don't know, maybe he was the first one to actually have it. No, I think there were a couple other guys, but he was up there, man. So he's always looking for the new stuff and ways to bring it in and make, get better results for his clients. So I wanted to, say that. And then on top of it, he's doing this oral appliance work, and we just had him present at the Council on Upper Cervical Care's ICA Symposium this summer. And then we also had him present at the Blair annual this year in October, because I really appreciate his perspective, and he's got great information. So
cool.
Yeah, I mean, you want to get into it? Is there anything in particular?
Yeah, so I was curious, Dr. Forgive me, I don't know if it's Preble or Preble. Is that the dentist that's in working with Dr. Chapman in his office?
That is
good question. Not sure.
Yeah, no, I think so. It must be
It would make
because,
sense, right? If they're going to do the
yeah,
research and they're in the same office
yeah.
now. And I know. So do you know when he actually got, he started to do that, where he actually brought on a dentist to actually do work? Not sure when.
I don't know, probably around this time, at least
Probably around.
10
Yeah.
years ago,
Yeah.
So,
Okay.
yeah, but he has a dentist in his office that he shares space with. Actually, I don't know. I think it was shorter than that because he just recently, not recently, but like I'm not going to throw a date out there, but within the last 10 years, he built a new practice in Utah and brought in that dentist to where they're
Got it.
doing that. But he's doing corrections, they're doing oral appliances, and then they're looking to get the longest hold time possible by basically stabilizing that end point of the craniocervical junction, that jaw being the terminal endpoint of the neck where the teeth come and contact on the front. If you can balance this and then balance that occlusion, you're going to get that nice stabilizing factor.
I don't remember reading it in the study here, but do you know kind of what I know that they took the radiographs pre any treatment, post adjustment, post oral appliance. Do you know when the measurements for the oral appliance were made? Were they before the adjustment or after the adjustment? Do you remember reading that?
After, well, at least, so from what I understand, I don't think it's described here, but what I know now is that he does it immediately after. So they do the correction, they do their measurements, and then they create the appliance.
Got it. So it's not like they do the oral measurements before the adjustment, the adjustment could change and then do it. They do it sequentially. That would make sense. Yep. And apparently he's seeing holding times apparently pretty extensive here.
Yep.
Yeah. That was actually one of my questions to ask you, to get your opinion on. These measurements are very detailed, and I'm curious if like a peer review kind of thing is going to be the next step for here, as far as to just go through all the work, go through all the measurements, and really make, just to make it more sound, make it more, I don't know, evidence-based, or, just so it's not one person measuring, but it's like, hey, these were the results. Then we had another, more doctors measure, and then, so.
Yeah, that's the next step. It's like you do a cursory study, you say, okay, I found these findings. Now we need to repeat this. I mean, 11 people is not a large study, right? We need to do this with 1,000 people. You do it with 1,000 people, okay, and we do it with different practitioners, then we've got something, right? So that stuff takes time and lots of money. But I know he's working on a lot of this. He's doing a ton of research right now. Good. So
well, that's cool. That's exciting. What year was the Westerson and Chilton
paper? 2015. It was the year that we graduated from the diplomate program.
Okay.
Yeah.
All right. Okay. Yeah. I mean, there's not a ton to go through with, besides all the details. If there's anything you want to go through in regards to specifics of the study, we can.
Yeah. I mean, I think it's fascinating, right? So he's talking, at least what I know of Dr. Chapman, is that he has said before that his average hold time is 1.2 adjustments for like the lifetime of the patient. I can't boast those numbers. That is incredible.
Yeah.
I mean, you're talking about, I think
it's
my average.
It's interesting to think about, when people ask, and we both work with, these dentists that use the appliances like the DNA appliance and different things. And, when patients ask me about it, or I refer them over, it's kind of like, I talk to them about the chicken or the egg kind of thing. It's like, well, the jaw is there, and then the occipital anal joints, right? Like they're so close. So it's just, I was curious what your thoughts were on what do you think the results would have been if they might have done, instead of the adjustment first? Yeah, exactly. Right. So the oral appliance first to fix that, then did the atlas-orthogonal analysis, and then the adjustment. I mean, to get better results than apparently he's getting is going to be a tough, a tough sell, I guess. But I'm curious what the difference would be, or if there would be any, you know, because they're going to be affecting each other so much.
Yeah, you know, that's a great question. And that's one I ask myself all the time. Like, really, overall, which joint is the one influencing more of the other? I'm a carpenter per se, you know, as an upper cervical chiropractor. So my hammer and nail is the upper cervical spine.
Yeah.
When I see a problem, I correct the upper cervical spine. If I were a biomimetic oral appliance doctor, I'm sure my hammer and nail would be an oral appliance.
Yeah.
So,
Yeah, but
you know, and I would go there first.
yeah, and it's interesting to think about, even for patients that uh you know, might not have, you know, craniofacial issues, or might not have airway issues, or might not have these problems that are going to dentists like this. But to have
Mhm.
that analysis done on every patient that has
Right.
upper cervical spine, to see how well they hold with that,
Yeah. Yeah.
that would be interesting. And maybe one doesn't cause the other, maybe they affect each other, period. And it would be, the research would be to figure out just what's the best order to do it in, right? What would be
Yeah.
the best order to get the highest percentage and the longest hold time.
And I have patients that I've shared with these dentists, and you know, it's some of them rave about their dental work. Get my camera to focus there. Some of them rave about their dentists, and some of them don't. You know, it's just like, probably like me, right? Like, some people rave about what I do and some people don't.
Yeah.
Where, you know, I'll get a patient that they spend large amounts of money at the dentist, right? So like with us, in a case visit, we're talking, you know, a couple $1,000s over 6 months to a year, right? A few $1,000s. With an oral appliance dentist, where they're talking about changing the bite and the jaw and the craniofacial structures, we're talking about maybe, you know, tens of thousands
Yeah.
of dollars,
Yeah.
right?
Yeah.
And these patients sometimes are a little bit frustrated with their results. And then, you know, what I find is that sometimes it's better to not do them at the same time. It's better to do one and then do the other, right? And so this is an interesting scenario where he's doing it, they're in office, but they're only doing one correction and one appliance, right? So where usually what you have is it's a dentist that's constantly having the patient come back and get adjustments to their appliance, and they're changing it, and the bite's changing, and then they get their headaches back. And you know, where if it were just one correction and then it held and they held their appliance, I could see that, you know, and just let it go and like see how that runs out.
Yeah.
Yeah, I mean, that might make a difference.
I think it's all, I mean, this is all still fairly new as far as kind of the working together and whatnot.
Right.
So, you know, maybe all the research that Dr. Chapman is doing now might answer some of those questions as well.
Well, and I think some of the cool stuff that Chapman's doing will be the airway. So he showed some crazy cool videos at the symposium and the Blair conference, where just even without a correction or without an oral appliance, he was having people sit and do this versus this, and doing pre and post. Well, like, this was the standard. He would do a scan on them, a CBCT, and analyze their airway, because with CBCT scans, you can actually just plot the airway and measure the surface area of it, which is a health value indicator, right? So, you know, that determines how well you're breathing, and that has a lot to do with airway and apnea and all the breathing problems that people have. And then he would have them do this, right? And it was incredible. The like, it would just close that sucker down. And you're talking about diabetes, heart disease, brain disorders, like, just you name it, right? So, you know, we're talking, this is the future of upper cervical, is airway and that analysis of how everything in the neck is working together.
Totally.
So it's the future. It's
Yeah.
just, how are we going to do it, you know?
Yeah. Yeah. Well, I mean, we've talked about it before, but you know, the financial aspect of it, you know, it's, most of the docs are doing it on their own dime, in their spare time, when they're running a business to provide for their family. So it's like, it seems like it's going to be slow going unless somebody can convince, you know, the NIH or some other entity with money to support this kind of stuff. But you know, that's a whole nother that's a whole nother can of worms.
We'll talk about that on our next paper.
Yeah.
We will.
Yeah. All right. Anything else to go over? Maybe touch on maybe for patients watching this, what kind of recommendations or what kind of guidance can we give them if they're maybe looking into, maybe they went to a dentist and, they're working on that stuff, and maybe they got recommended to an upper cervical chiropractor like us. What do you, what do you have to say for them, or any sort of guidance?
Yeah, I mean, I think anything, do it for a little while and, follow the practitioner's recommendations to a T.
Yeah.
Do it to a T. If you don't do what they tell you to do, that's, for us, that's doing your stretches and your exercises, sleeping properly, like exercising, doing everything, having good posture, all that stuff. If you're not doing all of that, you're not going to get the result, and then you can't blame it on anything other than yourself. So those results are there for you to be had. However, if you go through the treatment plan and you're feeling worse, or you're just not noticing some big changes, it might be time not necessarily to stop the treatment, but to like with I know with what you do, I've talked with you a lot, is that you get to a 4 to 6 month time frame, you do an exam and you say, hey, look, okay, you're holding this period of time, kind of like Joey Myles, right? Like he talked, okay, you're holding this period of time, we're going to check you on this frequency, which is usually at least like a month or two, maybe more, right? Just depending. And at that point, it's like, okay, what else can we do? What else can we add in? And I always look to refer at that point. And a lot of times I'll refer to a dentist, I'll refer to a neurooptometrist, I'll refer to a physical therapist, things like that, so that now it's time to add in those other therapies. And sometimes, if they've been going to a dentist for 6 months to a year and they're not seeing the great changes that they want quite yet, it's like, okay, did I do everything right? Okay, now it's time to add in maybe some good traditional upper cervical chiropractic care, and see if we can get that to hold a little bit better.
Yeah.
See if it goes.
Yeah. I like that idea as well, as far as if patient expectations aren't being met, communication, like every relationship, is really important. I have, we've got lots of videos on our YouTube channels now, and I get questions all the time. Hey, I've been under care for 3 weeks, I'm feeling worse, but I'm just like, did you talk to your doctor about it? Like, why don't you express it? And I try to tell them, hey, listen, talk to your doctor, tell them you're having that. A lot of times you'll get those symptomatic reactions, they're transient, they'll go away. But it's that communication, so if the things aren't going like you would expect, or like you hoped even, have open communication with your doctor. And, obviously if you can't have open communication with your doctor, maybe that's not the right doctor for you, but
right,
that would be good. Okay. Okay. Anything else?
Yeah. Nope.
Good.
Yeah.
Awesome.
Good to
All
go.
right. Well, thank you, sir. Thank you for the episode. Oh, one last thing. I shot Dr. Chapman a message, but he's probably super busy. I shot him a message a long time ago, but just to see if he would jump on and just kind of give his thoughts on this paper, and maybe even, like you said, update us on any of the newer, research coming out. So hopefully I can get him on as a guest interview podcast, and any docs out there listening that know him, maybe poke him and say, hey, you should go on the show. And
well, and I know he is working on some research right now of post airway changes, and that's what he presents on now. And those airway changes are amazing.
Cool.
And he's the only person that I know that's showing that. And Dr. Dania Tamimi, who I'm going to do the CBCT course with in April, she actually read for Chris for a while, and she talks about this stuff too. She talks about airway changes. She talks about craniofacial changes. And we were talking about this before we got on here, but, after a correction in this paper, they talk about the changes in the craniofacial orientation of the bones, which is huge. And that happens. I know some docs may not know that it does because you've not been told to look for it, but it does change. Things do change. That's how you get patients' eyeballs to focus better, right? That you're getting changes in the orbits, you're getting changes in the fluid flow behind the orbits. So these things happen. It's just, are we measuring them? How do we measure them better? And keep an eye on them. So
Yeah.
it's out there.
Yeah, it just made me realize that was a huge point that we didn't even touch on in the very beginning, was just the fact that it's incredible to just even think about the possibility of your cranial bones shifting and changing and balancing out after only doing an atlas adjustment. And yeah, tiny little atlas adjustment to do that. So it's pretty incredible. So it'd be cool to get some actual measurements, maybe on one of these shows, or maybe with Dr. Chapman, you can maybe, throw up a couple that are just at least, for the viewer visually noticeable, to kind of say, hey, look, this is what's happening. And so
the software we're developing for Dizzior, the Dizzior software we're developing in Finland will do that automatically.
Nice.
It'll measure all the cranial bones and their changes pre and post. So it's coming.
Awesome. All right, Doc. Thank you so much for your time, and we'll see you on the next one.
All right.
See you, Doc. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care and take care of your spine. It's the only one you'll ever have.